So thanks for the great introduction. I am giving this lecture from St. Louis. It is 7 degrees in St. Louis. Maybe it's potentially a little bit warmer in New York City where most of you guys are there. It's been a very, very tough winter for us, and I'm really looking forward to the spring. My name is Kaharu, and Haru means spring in Japanese because I was born in spring, so I'm really longing for the spring weather here. And hopefully, my talk today can warm up some of your knowledge and some knowledge gaps that you may have discussing about what to do with albuterol. This is my disclosure here. So this is the outline here that we're going to talk about the reliever choices to set up of the stage. And then we're going to do a little bit of pro-con debate type discussion about ditching albuterol here. Since, this audience I know they're very interested in environment too. So we're going to talk a little bit about environment effect of SABA, and then go into talk about the data in mild asthma and then also talk about the data in moderate to severe asthma. And then move on to the con debate and mainly discussing about the challenges of ditching, and then end up with future and possible solutions. And then be free to, put a question in the chat, or you can, we should have some time for Q&A so we can discuss this, rather, I would say controversy, but, rather sort of a difficult and challenging ditching albuterol discussion at the end. So the reliever choices, as you know, has been SABA as needed for over 30 years. And reliever is used as needed for rapid relief of asthma symptoms. And in our country, albuterol is a short-acting beta agonist here, but you can either use with maintenance medication with these maintenance inhalers that can use daily, and then the plus reliever, or just used alone. And this has been guidelines first choice over 3 decades. I have to show you the GINA guideline here. So, however, there are a whole bunch of new different type of reliever listed in a rather complex GINA guideline that you guys are probably already seen it before. There is the in track 1, there's the as needed low dose ICS formoterol here. And then if you just take the ICS and SABA together as needed is step 1 in here, the reliever. And then there's the as needed ICS SABA, and then the sort of traditional albuterol as needed SABA in here. And this guideline is rather complex, so I try to make it a little bit more simple here and made a little table for reliever choices. So I'm going to refer to this table throughout the talk. So this will be the first, not the first time that you're going to see this table here, sort of try to orient you what we're going to talk about. But we are going to talk about these 4 reliever choices. So the traditional SABA, which is albuterol here. We have the ICS formoterol, which could be the Symbicort budesonide formoterol, or the generic version of it that we have now, or the Dulera can be used as well, which is the mometasone formoterol. And then now we have the budesonide albuterol here, and 1 inhaler AirSupra. There's more to come. And then that option for 2 albuterol. 2 inhalers together, albuterol plus ICS. And I'm going to separate to be used in a mild and then moderate to severe, and then discuss about the evidence and the challenges here. So just gonna start with the poll here. I'm not doing anything really fancy. You can just type it in or just kind of think about it in your head though. So just wanted to see how you're ready to ditch or not the albuterol. So number one is I'm ready to ditch albuterol as needed in my patients and have been trying hard not to prescribe it. I have been using somewhat less albuterol as needed and using other options, but not quite ditching for everybody. And then number three is using albuterol like I have always been, but I'm thinking that I may gradually do it. This is just thinking about it, but I haven't done it. And then number four is not ready at all. If you wanted to just type it in and see, I'm just gonna look in the chat too. I see a 2, I see a 2, 4. Nobody has 1. It's nice to see the 4 as well too, because that could be the reality. Just gonna wait for a few minutes, just a few seconds maybe to see if somebody else is gonna want to put it on there. 3. So nobody is 1, I'm assuming. So it's more leaning toward like 3.4 or 3.4 have been telling patients to use them. I like this comment. Our pulmonologists have been telling patients to use less albuterol. I think we've been doing that for 30 years, but it's not working. But anyway, okay, all right. So it's probably between 2 or 3 or something around 3 here that I'm probably gonna see in the reality here. So it's going to start with setting a stage and then go into the pro-con debate here. So ditching albuterol pro. So this really set the stage of the SABA reliance here. So as you know, a lot of patients ended up only taking a albuterol SABA and then rely on it. And it's partly because it's very difficult to take the daily ICS, the average data that's showing for adherence to daily therapy in asthma is about 50%. The SABA use is overspread. This is a US data, prescription data, but 52% of all asthma patients only using SABA. And within that 52, 72% fill 2 or more SABA prescription per year. And this is also happening in globally too. 40% prescribe 3 or more SABA per year, which indicates poor asthma control. So SABA, SABINA 2 and 3 is an international consortium looking at the SABA use. And they have seen 40% or more prescription SABA per year. And this is a table figure that is showing from SABINA 3. This was a even bigger international cohort study. They're looking at the prescription pattern for over 8,000 patients. From 24 countries. So compared to taking 1 or 2 canisters, if you take more than 3, the risk for exacerbation increases with dose. So SABA overuse is associated with poor outcome. And also, if you use it regularly, there are other side effects that's reported that could adversely increase eosinophilic inflammation. You can have rebound bronchoconstriction and loss of bronchoprotection. So we do need alternative option that meets patients' preference and goals instead of just keep pushing the daily therapy, which we have been doing for over 30 years. And then now we have options. For this audience, I'm going to talk a little bit about the environmental effect from the MDI. So the healthcare sector accounts for 4.6% of global greenhouse. emission. It may not sound too big, but but healthcare sector does account for some global greenhouse gas emissions. As some of the older people in the crowd may know about this, we used to have the CFC propellant, which was phased out due to concern for depletion in ozone. That was completed in 2014. But then if you look at the sales for the MDI with HFA, which is the current propellant, has increased about 80% from 2015 to 2020. This is a figure that's showing the sales of MDI. So the big blue one is the HFA 134, and then the dark one is 227. So you can kind of see it has increased over the past 5 years or so. This yellow one is the DPI. So DPI has increased some, but overall the use of MDI has increased pretty significantly in the past 5 years. And the problem here is that HFA releases a potent hydrocarbon gases and does have high global warming potential. So this is the global warming potential number that is given to many compounds, and then it's basically comparing the number from the CO2, which is 1, and then see the potential by number. So the newer potential propellant, there's been development. It's lower, but if you look at 134, which HFA 144, which you use in most current MDIs, is over 1,000 and 1,300. And then the 227 that's used in Symbicort, asthma, HFA, Dulera is 333.50. But obviously if you compare it to CFC, it's much lower, but it's still you can see that the environmental effect, that the global warming potential is pretty high. Here you go. And then MDIs are the main source of the sales here. 75% of sales are MDI in the US. And then 60% is albuterol. So overall market in the US in 2018, 60% is actually albuterol. And if you look at the data from Sabina 3, so this was an international cohort looking at SABA use, so overuse SABA patients, so they define the overuse for those who use more than 3 canister per year. And those are the people who actually are responsible for over 90% of SABA prescriptions. So essentially, much of the MDIs are from the SABA, and then also concentrated on people who use lots of SABA. So I'm going to orient you with this very interesting study from Sweden. As you know, Sweden is very environmental conscious here. So and then what they did here is that they did look at the carbon footprint from these inhalers as listed on the top. Now they have a different name here because it's different from ours. So I did put what's the equivalent here on the top. So Relvar is equivalent to the Brio, Seretide is Advair, and Ventolin is our, we have Ventolin too, it's a SABA too. And then these three here, the Accuthaler and the Ellipta is the dry powder inhaler. And then this Evohaler is the MDI here. And then they looked at multiple phases of the life of the inhaler, and then looked at the carbon footprint for these inhalers. So you can see these two here, the MDIs have the highest and pretty high, about 20 times more of the carbon footprint here. And then which mostly happen in the user phase here, and the end of life when it gets wasted and disposed here. And then what they also did here in the same study is that they looked at in the individual level what would be the footprint reduction would be. So here they actually have sort of like this estimated CO2 saving in the individual level. It's coming from like a 35 kilogram planting a tree to all the way to changing the everything to plant-based diet for a year. And then looking at the effect of these inhalers relative to the reduction that we may have. So the biggest thing here that you see is the Evohaler here. So Evohaler is the MDI. So if you were to not use the Evohaler or the Ventolin, it will be the higher than avoiding all food waste. But again, the biggest sort of a contributor for the reduction is the Ventolin MDI, which also is part of my pro debate that using less MDI would be a environmental friendly option here. So there's been potential solution that's been placed. The HFC phase out is ongoing in the US and Europe. The inhaler is actually a very small portion of this HFC production. There's some other things like the refrigerant, which is the main cause of it. It's been going slow but sure phase out is ongoing. In terms of the inhalers, several manufacturers, AZ and Chiesi, has committed to launching MDI with low global warming. There's new propellants that's been developed. And then, overall, yes, use of SABA is probably a good idea for this reason as well. And then, so we're going to talk about evidence in mild asthma here to support the use of, support the ditching here. So here I'm going to orient you again to, we're going to talk about AIR, the anti-inflammatory reliever therapy here in ASIST Albuterol, ASIST SABA, and then the two inhaler together. So mainly these three columns here. So AIR is anti-inflammatory reliever therapy, which is the use of maintenance inhaler ICS with reliever. So just to recap again, for 30 years, we've been telling patients to use ICS daily and then reliever as needed. But instead of that, you will use the anti-inflammatory medication ICS here and the reliever medication on the right, which is a bronchodilator, used at the same time, not in a different time for relief of symptoms. And how it works is that you, for mild asthma, you would not have any daily therapy here. So there's a day that you don't use any, but then when you have symptoms, you use it as needed. And then when you have a flare, you will use it more. There's been many different terminology: as needed, PRN, on-demand rescue, symptom-driven, intermittent. But now I think I see more as needed term in the literature for this type of use here for AIR. Especially for mild asthma, it is a very important alternative. Majority of the asthma patients are mild, but they're not mild in terms of morbidity and mortality. 37% with acute asthma, 15% with adult dying from asthma actually only had weekly symptoms in the previous 3 months. However, their symptoms are mild and infrequent, so they often fail off of taking daily therapy, and it's very difficult to enforce it. There's been changes in GINA in 2019 and in 2020 that included this as part of their guideline. And some studies show that as needed base of use of ICS is a lot more patient-centered and also increase a sense of self-management here. And then GINA no longer recommends SABA-only use for asthma. We can discuss about this maybe after the program debate and what you guys all think about it. But in their guideline, they say we should not be treating even the mild intermittent asthma, not be treating asthma patients with albuterol only. So just to go through some of the evidence here, at this point, you all may be familiar with these multiple studies that was done in budesonide formoterol. So this is in our country, it's Symbicort, the generic here, budesonide formoterol in mild asthma. There's been 4 big randomized control, and there's more smaller studies there, but those are the landmark studies here. So compared to only using SABA, there's been about 60% of reduction in exacerbation. And then if you compare to daily low dose ICS with as needed SABA, the severes, I'm showing a meta-analysis here for the exacerbation in the bottom on this figure, but Noble Stars showed a significant reduction, but others are non-inferior for the severe exacerbation, but they can achieve that with a lower dose, about 25 to 50% of daily ICS. And then the symptom control in lung function, there's a small statistically non-clinically significant difference. And then the airway inflammation marker, FeNOs, also gets higher with the as needed use, but there's a small difference of 10 ppb. And then I'm going to switch to also talking about the separate inhaler taking. So this is a ICS plus albuterol at the same time. It is done mostly with beclomethasone ICS, so it's QVAR plus ICS. The studies are not big, and most of them is independent of pharma. So the evidence is not as strong, but you can argue, the Sigma studies that I showed earlier that were all funded by the maker of the budesonide formoterol. These are done mostly by the investigators, and then they use separate inhalers for ICS, except for one study. There is, in children, there's Trexa and ASIST. In adults, there's a POPI study. This was the only one that used a combined medication. And then there's well-cited. And essentially what it shows is similar asthma control compared to daily therapy with less ICS dose. So this is fresh from the oven here. We actually may not be quite out from the oven just yet. So this is in regards to the budesonide albuterol, the new inhaler on the market, which has the ICS SABA component, and called Betula. It was done in 12 years and older with mild asthma, and they had a fully virtual phase 3 randomized control trial. This was again funded by AstraZeneca. 24,000 people, 2,400 people total enrollment. And then they just reported this in the October 2024 college meeting that they showed 47 risk reduction in time to first exacerbation. The publication officially is not out yet, but with what we've seen here, it's probably going to be going into a high profile journal with a pretty impressive data risk reduction here with a positive finding, which is not actually too surprising. What I have in this figure, I thought it was kind of interesting to just kind of show how this study was done, because it's a very modern way of doing a clinical trial. So this was fully virtual. So the participants stayed at home, and then they actually used a virtual visit with the Science 37 platform. So they did the e-consent, telemedicine visit, and then got all of the outcome through messaging and using their platform. And then they also deliver their medication from directly to the patient. And then they also had like some monitoring going on. They put the device on the medication to monitor what happened with them. They also had e-recruitment, which used the media and social media to get them recruited. And then it has a pre-screener who's a web-based, and then also had a concierge So they did not really do it in a traditional way that we use, that we have a site and they have a in-person visit. They actually was done fully virtual, and probably they spent very less money to do this pretty large study here. So what about moderate severe asthma for ditching albuterol? So just to orient again, we're going to talk about MART here, and then talk about ICS-SABA, and then they separate using the separate inhaler together. So everybody probably knows about SMART or MART therapy at this point, but just to make sure, because it's rather complicated, they have many options here. So with MART, compared to the air only, that you would have a maintenance dose here that you would ask the patients to do. So there is daily therapy for that, but then you would use the reliever on top of it with one inhaler, which is the ICS formoterol that we can use. MART therapy has lots of data with supporting that. But again, all study is done in budesonide formoterol. There's strong evidence from very small children, from 4-year-old to adults, and overall showing risk reduction for exacerbation about 30 to 40%. So I'm shown in this figure, this is a large meta-analysis for over 2,200 patients, and then it's essentially compared to the same dose of ICS-LABA plus as needed SABA, or higher dose, both essentially showing the risk reduction up to about 30 to 40% for exacerbation here in multiple studies. With this strong evidence, it is a preferred therapy for step 3 and 5 for GINA. We just saw in the earlier slides, we did look at the GINA guideline there briefly. I'm not showing the NPP guideline because it's kind of rather complicated, but it is on the NPP guideline 2020 as preferred therapy also for 3 and 4. Just a little bit about the formoterol to give a little bit of something to consider here. So formoterol, like we already talked about, is the key of these quick combined inhaler reliever, because it is a LABA, the long-acting beta agonist, but it is quick in onset. So you show, I'm showing a very old data figure from an old study here, but this is looking at the time and then the lung function. So the formoterol and the SABA has a very quick onset and increasing the lung function here, and then open up the bronchodilation effect here. But the traditional LABA takes a little bit longer to have that effect. So this quick really onset is what we actually utilizing for all of these sort of as needed use though. But then there's maybe a little bit more here. So this is a very old study, almost coming to 20-year-old, and we are not going to replicate this because we will never use formoterol for as needed anymore. But it was a very well done study, essentially tested the use of terbutaline, this is the SABA, or formoterol, so this is formoterol here, or as needed budesonide formoterol on top of using a daily ICS 1 puff twice a day, so 164.1 puff twice a day, and then see what happens with them. And you can see it's no surprise that budesonide formoterol as needed people did better, right? But you can see this blue line with formoterol. So formoterol people actually did better than SABA only. So this kind of indicate, and it's pretty a big difference here. So maybe there's something more than just a bronchodilator that happens. There's some studies that's showing that maybe there's some anti-inflammatory effect, or there's some other added effect that formoterol has as a reliever that may be potentially better than SABA as well. So maybe formoterol does matter as a bronchodilator that we've seen in these positive effects that we've seen in all these data. And then following up a little bit more newer data for our new kid on the block. Well, so this is the ICS SABA, the budesonide albuterol, air supra that we have in the market. This is a landmark study, Mandala, funded by AZ. AZ, again, this product is available in the market based on this study. And they basically randomized 3 to 5 step 3 to 5 patient uncontrolled, and then look at the exacerbation, and it showed a hazard ratio of 0.74, about 26 reduction of exacerbation with this higher dose combination, which is the 160. So based on that, this is on the market. And then lastly, on the moderate to severe, we're going to talk about PREPARE. So this is study tested what they call a PARTIX, which they use the albuterol and QVAR together. What was different from this study, the Mandala, it was a pragmatic in Black and Latino patients with moderate severe asthma. And then what they did was that they were told to use 1 puff of beclomethasone QVAR with 1 puff of albuterol MDI, so matched puff for beclomethasone and albuterol. And then if they use nebulizer, they were told to use 5 puffs of the nebulizer plus whatever inhalers is on. So the advantage here is that you don't have to switch the inhaler. They could be on anything like Avir, Breer, or whatever that's going to be, and then just told to do differently for their reliever. So there's a little bit, and then what they show is about 15% reduction on exacerbation, and also they met some secondary outcome like missed days of school and work and usual activity. Couple caveats to the study. So I already mentioned 2 separate inhalers. So they gave these inhalers and then put it together in a little pouch that they can actually take it with them. Medication was provided by them, so there was not an issue for a prescription of access to care, and then access to medication, sorry. And then they ended up using 1.1 canister for beclomethasone per year, the intervention arm. And then the nebulizers was really high, 67%. I'm going to come back to this issue in the con debate here to discuss. Okay, so that was a pro. So I'm going to move into con. I know I did a poll a little bit earlier, and then everybody had a 3 or 4. So there's probably a lot to talk about in con as well. So I'm going to try to dissect a little bit about the con debate. So we're not ready to ditch albuterol as a reliever because maybe it's the patient selection, maybe it's the patient behavior. And then albuterol use is too widespread. Maybe we don't really have enough evidence in some areas. We just talked about the neb users issue. And then there's significant implementation challenges. I'm sure when you try to do this, you have already experienced problem with insurance coverage and cost. So a little bit about the patient selection. So I think to prescribe the budesonide formoterol or ICS formoterol to somebody who has mild persistent, and maybe it's not really that difficult to do, but the issue comes in with the mild intermittent patients. So the argument that the GINA has here is that if they look at all the data for budesonide formoterol, even the intermittent asthma group that they had less than twice a week symptoms, they also benefit from it. So, and then actually it's many of the subgroup analysis for the intermittent patients, they are actually showing benefit. So that's the argument that's saying they should also be treated with the ICS contain medication. But if you look into, and this is a busy slide, but I listed some of the inclusion criteria for these landmark studies, and then the GINA steps 1 and 2 that this therapy is indicated. And you can see that these patients are mostly symptomatic. Maybe they have to be uncontrolled and they have more than twice a week symptoms. Or here on stigma 2, also twice a week symptoms, and then exacerbation. Noble Star study, which was more pragmatic, they also needed to have 1 exacerbation or using albuterol as well too. So these are not specifically for the intermittent patient. This was for mild, and the intermittent patient was included. So all, the landmark studies did not include all spectrum of mild patients that we were interested in, see if we wanted to ditch albuterol or not. And then also the subgroup analysis. I know this is a little small, that you cannot see, but the point is that all these subgroup analysis that they did with budesonide ICS as needed, there has not been a population that we can say that this therapy will specifically work, except for if they had history exacerbation. It's shown in one of those here. Here, there's a difference here. And whether if they had exacerbation, okay, fine, I think you can consider using it. And I think there's a pretty strong data support to that. But if they don't, on somebody who's mild intermittent and has not had an exacerbation, there's no sort of asthma character that we can differentiate the use here. So there's a issue with patient selections, clearly part of the con debate here. And what about patient behavior? So we did discuss about the neb use here, and SABA overuse. So SABA use is widespread. I shown this data earlier too, but it's going to repeat here. 52% of all asthma patients only using SABA. This is a pretty striking data from looking at the refills and medication practice here. And then 62% had at least one exacerbation. You can say, well, they're undertreated. But on the other hand, 38% did not have exacerbation. So what are we going to do with this 38% if they did not have an exacerbation? Are we actually going to ditch albuterol or not? And then the neb use is also widespread. I was talking to some of the colleagues in Canada and Australia, and they actually use mostly MDIs, even in the ER, but we don't, as we know. And high nebulizers, 67% in moderate to severe asthma in a prepared study, and then in that 67%, 50% use more than once a week. So we do not know, if they started to use neb, and then if you don't do the MART and increase the ICS that way, well, what's going to happen? We still don't have really a data there. And then also in many of these patients, it's shown in this reference here too, but we also have a live experience that they love their nebulizer. They're reluctant to give up their nebulizers. There's implemented challenges. I'm not going to go into this too much here because this is in itself a talk on its own. But ICS mineral as needed in this country is not fully not FDA approved for its use as needed. It is approved for only for daily use here. So there's issue with still insurance coverage. I see more coverage here that can happen now, but if you were to try to get the second inhaler in a month, that's always a issue here with insurance coverage. And then there's cost. So albuterol is often the cheapest, and if you were to switch to something else, it's most of the time it's a whole lot more expensive. And then you gotta have to explain patient how to do it. You gotta have to have a good method of doing it, especially if you are going to switch your maintenance inhaler completely to budesonide formoterol, or you're gonna say, well, you're gonna ditch your albuterol and then you're gonna use something else as needed. Then you gotta have to explain how to do it. And these are symptom-based therapies. So there's under perceivers and over perceivers. And then we just talk about the patient's SABA reliance. There are some good data for taking two inhalers, but well, guess what? In reality, it's really not practical too. And then there's also a unanswered concern about this therapy too, which basically around the dose of the ICS. So if we actually go into step down to use it as needed from daily, is it actually too little? So the question is it okay to step down from daily therapy, daily ICS to only as needed? There's some concern in those Sigma studies. They did show that the FeNO increased by 10. Now, it is that clinically significant? It's a small difference, but then if we were to leave it like this for 2 years, 5 years, 10 years, is it going to have some effect? So I'm just showing some data for a very old study again here, looking at biopsies from the bronchial biopsies here. And then they actually looked at the intermittent asthma. And so even in the intermittent asthma, they have very few symptoms that you can see, but compared to asthma, you can see compared to the control subject here, they do have evidence of airway inflammation, epithelial shedding, basement membrane is thicker, and then they have mast cells and EOs and inflammation there. Even if they only have intermittent symptoms. So is there a threshold or for too little ICS? If we were to step down, we still have no clear answer to that. And then there's a concern for too much ICS, especially if you're going to use the SABA ICS containing SABA or LABA more. If you were to use it more and more and more, is it going to cause problem for the patient? Just to give a context for this. So in the PREPARE study, this was a study that was used QVAR plus ICS, and it was one of the very pragmatic study, but they only used 1 canister per year. So this doesn't sound too bad if you were to use 1 canister of QVAR per year. So that doesn't seem too bad. In Mandala, this was a study in ICS budesonide. They use a little bit more. I'm sorry, this is a little bit small here, but essentially this here is showing how many puff per rescue that they used, and then they're looking at like the percentage. So there are days that they did not use none here, but most of them are about 1 to 2 or 3 to 4 here, and then an average dose that they use is about 2.6 per day in Mandala. And then the point is that a very few times, about only 2% of them, they actually used 8 puffs a day, which is 4 times a day. So you can argue that, well, we only look at the higher dose that we allow patients to do, but then they're very, very likely that they're not going to use a very high dose, only 2% of them. But we still don't know how much is too much and whether that's going to cause a problem here. So I'm just going to wrap up with talking about the future here. So there's significant research gap for in this area, which is lack of data in children for as needed for formoterol. So only the air use as needed for formoterol. We do not have that data. And then we touched on it a little bit, but which patients to use as needed ICS, which patients to keep daily ICS, we don't know the exact answer to it. And then the ICS formoterol versus ICS SABA, both are coming from the same company, and they do not have any plan to do this, but it would be very nice to have a head-to-head comparison. And then a moderate to severe asthma, MART, either comparing the MART to the ICS SABA as needed, that is also an area of gaps as well. And then when to step up from MART or step down from MART for as needed therapy, we still don't really have a question, an answer here. So there's a little bit of a ongoing study that we are slowly but surely try to answer some of the questions. So there is this Albuterol study in as needed budesonide albuterol that is done in adolescents now, and then they're planning to go to the children soon after this. It's going to take a couple years to have this data, but the as needed budesonide albuterol, so this is air supra use in children, may be in the horizon. And then in the moderate to severe, we talked about the nebulizer, and we are currently doing this study called iCare, which is led by Dr. Israel in Brigham. It's a PCORI funded study, open label pragmatic study, and we're doing a feasibility phase, but it's planning to enroll more than 2,000 patients, which is comparing the PrecICE, which is the 2 inhaler version that was in Prepare, ICS plus SABA, and then the MART in the neb users and non-neb users. So the study will answer one of the questions that we have with the neb users. And then there's also competition for ACS SABA. So Air Super is the only one that's available now, but FLAIR study is done in Teva. They have developed the fluticasone albuterol, which is the ongoing study. For clinicians, so we talked about budesonide formoterol, but technically you can do it with Dulera mometasone for formoterol as well too. We recommend using 100 dose instead of the 200. The 12 and above, the instruction is for air that you can tell them to use ICS formoterol 160 as needed and take 1 inhalation as needed and maximum 12 puffs a day. In SMART, you would add either 1 or 2 puffs of that daily dose in addition to the needed dose. And then we definitely need shared decision making to make it happen. Just to mention some of the work that we've been doing. So this is AIR for You pilot study that I've been working on for about 2 years now. We have developed some implementation tool, the action plan for AIR, the QR code with videos, patient selection sheet, and a provider information packet, and no template for EPIC. And we pilot tested in 3 community provider sites. And then we have some scale-up planning, and this was presented last year, and then a manuscript is in preparation. It's to facilitate the implementation in a community providers. Mainly this was for mild asthma. And then within our work, we have developed some of a nice action plan. So the one in the left is for AIR that my team developed. These other ones here is from my colleague, a junior faculty in our division, James Krings. He's been involved in implementation with SMART, and then so with the design people have made very nice SMART therapy action plan as well. So this could facilitate some of the use in the provider side. So it's going to wrap up with a take-home message here. So asthma relievers. I think I convinced you that even if you are pro or con on the albuterol ditching, we all do need to work together to decrease SABA overuse, because that is a huge problem in not only US but globally. We went through multiple options that are available for relievers, and more should be coming. We also went through the pros and cons. So that also needs to be shared with the patient, needs to the shared decision with the patients. And you can see, with all of the cons that I mentioned, not all of the patients will want to change, but there are some good reasons for change if you think that the newer as needed ICS therapy is good for your patients. There are good evidence available for AIR. Mostly the newer evidence is for AIR because the SMART evidence is done pretty well back, but and then more for that is coming, especially surrounding ICS SABA. There are lots of hoops for implementation, but we've been making small steps toward broader use compared to a couple of years ago when this first came up in the guideline. Nobody knew about it, but I think we've been talking about it and slowly but surely making stride into implementation.